Track 3. Test 1 Exam Practice Listening. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a cardiologist talking to a patient called Bryn Turnbull. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
So, Bryn, I've got your notes here, but as we haven't met before, it would be good to begin by hearing things from your perspective. Could you tell me how your condition started, what treatment you've had, and anything else you feel I should know?
Well, it all started about 4 years ago. I began to notice my heartbeat. You know, it's always there, but you don't usually notice it. Well, at certain times, I did. Anyway, what I realised was that my heart was fluttering, if you know what I mean. The feeling wasn't there all the time and I wasn't in any pain. But I went to the doctor and she asked if there was any breathlessness, which there wasn't, and whether it came on at particular times or after particular activities, which it didn't. So she said just to keep an eye on it and, go back if it got any worse or if I got other symptoms. I mean, I was a bit concerned not to have any treatment because my father had heart disease. He had a bypass operation eventually, but he didn't live long after that. So you can see why I was worried.
Yes, sure. And did other symptoms develop?
Well, yes. That was about 2 years ago. I mean, this only happened on one occasion, but I suddenly noticed that my heart was racing. That's the word I'd use to describe it.
Right.
I was cycling at the time, but nothing too strenuous. Anyway, I had a rest and the moment passed. But when I got home, I went back to the doctor who referred me to a cardiologist. He did various tests, an ECG and stuff, and he got me to wear a Holter monitor for a couple of days to see exactly what my heart was doing. That confirmed that I had an irregular heartbeat. He also told me that I had something called mitral valve regurgitation, but that it was probably a birth defect, so not something new to worry about.
I see. And what about medication?
Well, he put me on beta blockers, just a low dose, and he said I should only take them when the irregular heartbeat was troubling me, so that's what I've been doing. I suppose I get through about 50 or so in any 6-month period. There are times when I'm taking them every day. Then weeks can go by without me having to take any at all, and they do seem to do the trick. The only problem is that they do have side effects, like I tend to get nightmares, and that's pretty unusual for me actually, and my hands and feet get very cold. And another thing is, my partner says I'm irritable when I'm on them, and I guess she's right. But who knows whether that's the medication? I mean, it could be the heart problem itself.
I see. And what about your current symptoms? What brings you here today?
Well, what happened was I had to go on a business trip to East Asia and I was taken ill on the flight home. That was a couple of months ago. I assumed I caught flu out there, but the doctor thought it could be pneumonia. Anyway, she gave me antibiotics and it cleared up okay. But then I started getting a pain, in my shoulders mostly, though I do sometimes feel it in my neck too, occasionally even in my jaw. I mean, it's not a sharp pain, and it doesn't seem to be related to movement. It's more like a dull ache, if you know what I mean. And it's not there all the time. Again, it's just something that I'm aware of. Anyway, given my other problems, the doctor thought I'd better get it checked out, so here I am.
Sure. Well, thank you for all that background, Bryn. What I'd like to do now is to...
Extract 2, questions 13 to 24. You hear a primary care physician talking to a new patient called Jason Weiss. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
So, Jason, I understand you've just moved to the area. I've got some notes here from your previous doctor, but it would be good to hear things from your perspective. Perhaps you could start by telling me a bit about any illnesses or treatment you've had, and anything else it might be useful for me to know.
Well, my current problems all started about 18 months ago. I went down with a bad cold that quickly turned into a chest infection. I thought it was just a bug that was going round, but it was quite bad, and I was having problems breathing. It's hard to describe, but I had a sort of stinging feeling in my chest whenever I breathed in deeply. Anyway, I did gradually get better, but I was left with a dry cough. I just couldn't seem to shake it off. It wasn't there all the time, but just when I thought I was all back to normal, it would suddenly re-emerge. That happened a number of times. After that, I started to get other symptoms. I'd lost quite a bit of weight without even trying. I noticed that my trousers were getting really loose, but I was eating normally. And I was sometimes getting this strange feeling in my throat, as if I wasn't swallowing properly. Then, at night, I'd suddenly wake up with a really bad taste in my mouth. Anyway, I went back to the doctor about that and was told I had a hiatus hernia, as well as a mild case of GERD, but not to worry about it. But when I mentioned that I was still getting the chest problems, she decided to make a referral to the pulmonologist.
And did you have some tests?
Yes, a number actually. The first one I had showed I didn't have asthma. I didn't really think that I would have, but they explained how they needed to rule it out. I also had a high-resolution CT scan. I think they said they wanted to see if I'd started to show signs of pulmonary fibrosis, but again, that came back clear. What it did show, however, was that I had hyperinflation in my lungs, and they came to the conclusion that it was probably mild COPD. I was asked lots of questions about my lifestyle, now and in the past, particularly about smoking, and, of course, my father loved his pipe, so I guess I was a passive smoker throughout my childhood. I've never actually smoked myself, though.
That's good. And recently you've been getting other symptoms?
That's right. I've been getting pains in my joints. It was just the odd twinge initially, but it's been getting progressively worse. It started off in my knees, but I'm now getting the same sort of feeling in my wrists and ankles. I've been going to physical therapy and taking painkillers, but I've not noticed any great improvement. But you see, I'm a train driver, so I'm not getting a lot of exercise, and that doesn't help. When I was younger, I used to do a lot of skiing, but I had to give that up after I fell and broke my thigh about 5 years ago. I was lucky I didn't need surgery, but I was out of action for months. At first, I thought the joint pain was related to that, but now it's spreading, I'm not so sure.
And what about the rest of your family? Any health issues there?
Well, my father eventually died of emphysema, and that is a cause for concern. But I should also tell you that my grandmother on my mum's side had pernicious anemia. I'm aware that there's a family weakness there, on the female side at least, because mum's just been told she's got leukemia. That was a shock because it just showed up in a blood test. She's had no symptoms. I mean, it can't be very advanced, but it is worrying. Anyway, the rest of the immediate family are fit and well as far as I know.
Well, Thanks for all that background, Jason. What I'd like to do, I think, is...
That is the end of Part A. Track 5, Test 1 Exam Practice Listening. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a senior hospital nurse briefing her team about some guidelines. Now read the question.
Now, given the ever-increasing risk from transmissible diseases, many of us are being required to wear personal protective equipment, including masks or respirators, much more often, and often for much longer periods. As I'm sure you're all aware, this can result in pressure damage to facial skin, something the hospital's keen both to raise awareness of and to address. New guidelines are in place that advise us how to self-manage skin damage if necessary, including guidance on the care of damaged skin and about appropriate dressings. The guidance also underlines what we should all already know: how to ensure that PPE is correctly fitted, how to make best use of skin barriers or protectants, and the importance of staying hydrated. I'm going to circulate the link so that you're all up to speed on these latest guidelines.
Question 26. You hear a doctor talking to a medical student who's going to observe her consultation with a patient. Now read the question.
So what I'm going to do today is a physical assessment of Mr. Jodrell.
Okay.
Mr. Jodrell's a 60-year-old male, and I've already been over his medical history, family history, and medications. Mr. Jodrell has a dairy intolerance and takes statins to control his cholesterol levels.
Right.
About 12 weeks ago, Mr. Jodrell underwent a right colectomy due to ischemic colitis. Since then, he's been recovering well, has no particular concerns, and he's attending today for an annual review that would have taken place anyway. So I'm going to do a very thorough head-to-toe assessment of Mr. Jodrell, starting with his head. I'm going to be asking him all the standard questions, picking up on any replies that indicate there may be a cause for concern. For example, if he feels any discomfort or tenderness when I palpate or check his articulation, that sort of thing.
I see.
So if you have any questions, I'll be happy to answer them afterwards.
Thanks.
Question 27. You hear 2 hospital nurses conducting a patient handover. Now read the question.
So in bed 4 we have Mrs. Singh, a 65-year-old female. She was admitted last night via the emergency department.
Right.
She'd been woken in the early hours by a sore throat and swollen tongue. She reported difficulty swallowing and her breathing was partially obstructed by the swelling. She also reports esophageal discomfort and she's refusing liquids.
Okay.
There are no signs of a rash, itching, chest pain or nausea, and no history of allergic reactions. She couldn't think of anything that might have caused this, though it might be worth running through that again with her.
Sure.
She's been afebrile for me. She was given IV antihistamines and an anti-inflammatory in ED, and the swelling's come down.
The plan is for an ENT consult to rule out an abscess or a foreign object, and then a pharmacological review. Those are both in hand.
OK.
Question 28. You hear a community nurse visiting an elderly patient in his home. Now read the question.
So, before I put a fresh dressing on, I'm just gently washing your legs to get rid of this flaky skin. That'll keep the new skin healthy. But I'm being very careful not to create any new wounds. Is that okay?
That's fine. I can't manage much myself these days. I hardly ever get out of the wheelchair, actually. I even slept in it one night. And I'm afraid I've not been using that cushion you gave me. It gets in the way when I try to do anything and makes me feel too high up. Could I have a smaller one? Or even a different chair?
Well, we may need to consider that, actually. Your legs are coming on fine, but we don't want you to develop skin problems elsewhere. I'm going to talk to the doctor to see if we can get something sorted out for you.
Thanks, nurse.
Question 29. You hear part of an induction program for new members of clinical staff at a hospital. Now read the question.
OK, so this morning we're looking at the hospital's electronic medical records system. Now, I expect you've used similar systems before, but you need to engage with the specifics of ours and be totally on board with its functionality. So that's our aim today. A key feature of this system is that you've got a single sign-on for most applications. You just enter your username and password once when you log in, rather than each time you use a separate application. Now, this makes life easier and means you get to spend time with your patients rather than staring at a screen. On top of that, some medical equipment's already integrated into the system. This is great from a patient safety perspective because there's no need to transfer data from one machine to another, so you avoid those inevitable slips where you type a digit wrong and don't notice.
Question 30. You hear part of a briefing meeting for staff in a local health centre. Now read the question.
So, Mustafa, tell us about any patients being discharged from hospital this week.
Well, first up, we've got Elaine Stokes, a 67-year-old female who was admitted following a fall, but who's now fully mobile. But she has vascular wounds on her feet that need to be dressed daily. She's had a procedure to improve her circulation, so won't need that doing long term.
Okay, so we're providing home visits?
That's right. We're doing that because another thing the patient needs is eye drops 4 times a day to treat bacterial conjunctivitis. Our main goal is to get her to use an auto dropper to reduce the number of visits. She's not keen on the idea, but whoever goes needs to be moving towards that. For the first few days, she'll be cared for by her son, just until she gets used to being back in the home environment, and hopefully will have his support.
That is the end of Part B. Track 8. Test 1 Exam Practice. Listening, Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with a nurse called Samira Hedden, who works for a charity that helps families affected by childhood continence issues. You now have 90 seconds to read questions 31 to 36.
I'm talking to Samira Hedden, a nurse working for a charity that helps families affected by childhood continence issues. Samira, childhood incontinence is often described as a hidden problem. Why is that?
Yes, it's very much a hidden problem, I'm afraid. It's estimated that around 900,000 school-aged children in the UK are affected.
Really?
Issues like daytime bladder control, constipation and soiling can have a devastating effect on a child's academic and social development. That it's so little known is mainly down to the fact that families don't come forward and ask for help. Parents are often too embarrassed or simply persist in the mistaken belief that their child will grow out of the problems. And of course, the youngsters themselves don't want their peers and teachers to know what's going on, so the issue may never be raised with the school. Unless there's an episode in class, teachers may simply not realise that a student has a continence problem.
The charities recently led a project to raise awareness of the issue in schools.
That's right. That's right. You see, government guidelines on managing medical needs in schools don't specifically highlight continence conditions, and there's a lack of training for school staff in this area. What we found through our work were enormous variations in how the issue's handled in schools. In some, incontinence was perceived as a behavioural rather than a genuine health issue, and parents were expected to deal with it. So, for example, children might be sent home or parents called in to deal with episodes, whereas in other schools, staff took more responsibility for managing the problem and supporting students. That disparity didn't seem fair to us.
So, tell us about the focus of the project you set up.
Well, it was a team effort. We began by organising a survey of affected parents to see what effect school policies were having. We found that 90% of youngsters with continence difficulties took time off school as a result. In 30% of cases, the absences exceeded 2 weeks. But what gave us a clear lead in terms of the aims of our own project was the fact that our helpline was getting increasing numbers of calls and inquiries from schools. Staff wanted a better understanding of their responsibilities and ideas for supporting the children in their care. This was an area where we felt well placed to provide useful input.
So, how easy was it to set that up? Were there any challenges?
We set out to produce a set of clear guidelines on bladder and bowel health in educational settings. An online search allowed us to identify what information already existed, and we set about collating that information, ensuring it was up to date and filling in the gaps. That part was fairly straightforward. Harder was deciding whether to pitch the document at early years, primary or secondary education, because the issues are different. After much discussion, we settled for one document that would encompass the transition of the child through the entire education system. A draft document was drawn up and widely circulated. We wanted to take on board the concerns and comments of parents and school staff, as well as a range of health professionals. That took time, but it was well worth the effort.
So, what do you see as the main strength of the document?
Well, it's great to have one clear point of reference that clearly establishes the responsibility of the school for supporting children with continence needs. But for me, what really makes a difference is the recommendation that a care plan is drawn up for each child, outlining that child's particular needs and what support is in place to deal with episodes of incontinence. The document also supports teachers. There's an index of continence conditions, aids and treatments. So it also has a training function, and there's material that can inform CPD sessions and trickle-down training.
Finally, could you give us an example of how the document's being used in practice?
Sure. I'll tell you about one 12-year-old student. Let's call him Johan. Johan has occasional issues with daytime bladder control. His greatest fear is not getting to the toilet in time, becoming the centre of unwanted attention and losing face. It's a fear that can exacerbate the condition. So, Johan's care plan makes provision for an emergency bag containing clean underwear, wet wipes, etc., plus an access card establishing that he may leave the classroom during lessons without asking for specific permission. He's also got access to a designated disabled toilet where there's more space and privacy. Basically, although he's rarely used these arrangements, the fact that they're in place has turned Johan's life around. He no longer misses school when he's having continence problems, and happily those problems are now getting rarer.
Now look at Extract 2. Extract 2. Questions 37 to 42. You hear a junior doctor called Ewan Garstang giving a presentation about different ways of dealing with large numbers of patients in an emergency department, ED. You now have 90 seconds to read questions 37 to 42.
My subject today will be a familiar problem to anyone who's spent time working in a hospital emergency department. You hear the same story the world over. The service is often stretched to the limit, resulting in overcrowding.
The effects of ever-increasing demand on limited healthcare resources are often most keenly felt in emergency departments. Research shows that overcrowding not only delays the commencement of emergency treatment, frustrating as that is, but, crucially, that levels of adherence to accepted standards aren't always maintained, making the service less reliable and potentially less safe. And there are other, less obvious downsides too. For example, patients giving up and leaving without getting the treatment they need, as happens in 2% of ED visits in the USA. Because they'll be back once their symptoms worsen, and treating them will place an even greater burden on hard-pressed staff and scarce resources. So, what factors lead to overcrowding in ED, and what remedies have been tried to reduce its impact? As any ED staff will tell you, it's not just a question of rising demand. Other factors impact on overcrowding in the ED. Firstly, there's what I like to call intrinsic factors. For example, the way the building itself is organised and how patients move through it can affect the flow. ED staff themselves should be encouraged to come up with ideas for streamlining existing practices, especially in terms of the everyday practicalities, like where chairs are positioned for patients or how to keep patients informed of likely waiting times. What I call extrinsic factors may be out of their control, however. For example, a shortage of beds on other wards can hold up patients' progress through the ED. Solving this issue calls for input at a higher strategic level. In between, however, there are policy decisions that can influence the flow of patients and should be considered by ED managers. Let's look at some examples. The overall aim of any changes has to be reducing the time each individual patient spends in the department. Nurse triage is the traditional way of ensuring throughput, and it's been shown to reduce both morbidity and mortality. By picking up on red flags amongst the patient's symptoms, the triage nurse can allocate scarce resources to those patients with the greatest need, and this is necessary to prevent harm. But, as with any fast-track system, there's always a risk that the queue of non-fast-track patients then builds up. In other words, although patient flow is managed, throughput isn't actually improved, and overall patient satisfaction may fall. Something else that triage can allow is what's called streaming, where patients with similar conditions or needs are allocated to a particular work stream within the department, each with its own dedicated medical, nursing and ancillary staff ready to deal with those specific needs. Streaming has been shown to speed throughput, but works best when staffing levels are high and signposting for patients is clear. It's not practical in smaller units, however, where redeployment of limited resources may be needed at short notice to respond to changing needs. Another variant on the triage model involves doctor-led triage. Research has shown that having an emergency doctor involved at the triage stage means that key decisions, like whether a patient should progress through the system or be sent home, can be made much earlier, thereby cutting down waiting times for individual patients and potentially reducing the overall number of patients. Indeed, those with the longest potential wait can be taken out of the system altogether. But you have to ask yourself whether these doctors wouldn't be more valuable elsewhere in the process. An attractive alternative idea is to have a primary care physician dealing directly with less urgent cases following triage, thereby taking the pressure off the emergency specialists. Although this has been tried, as yet there's insufficient evidence whether this speeds patient throughput. I'd say it's an idea worth pursuing, however. Another option to consider is whether point-of-care testing could speed things up in the ED. In the traditional model, a lot of time is taken up waiting for the results of tests and investigations, even where this is speeded up by nurse triage, which to my mind should be standard practice, but often isn't. Point-of-care testing, on the other hand, involves moving the most commonly ordered investigations out of the laboratory and into the ED itself. Blood samples are the classic example. Where nursing staff have been trained to take and analyse these, improvements in patient flow have resulted. But the jury's out on this because, as well as placing an extra burden on already overstretched staff, point-of-care testing has none of the cost advantages of the centralised laboratory, except perhaps in the very largest hospitals.
That is the end of Part C.